and our today's topic of discussion is methods of diagnosis of dental caries. As you all know, dental caries is very much common thing in our dentistry. So we should know how to diagnose it properly, and according to that we have to choose our treatment plan. So starting with, caries diagnosis is the art or act of identifying a disease from its signs and symptoms. In order for a clinician to make a relatable clinical diagnosis, certain diagnostic test is required. This test is usually assessed in terms of specificity and sensitivity. Specificity means ability of the test or observation to clearly differentiate one disease from the other, and sensitivity means ability of a test or observation to detect the disease whenever it is truly present. In simpler language, we can say specificity means differentiation between two diseases, and sensitivity is one answer question, either it is yes or it is no. To better understand these concepts, a table of the results of clinical trial is given here. This side we have a test which you are going to apply, and this side we have a gold standard methods. It means what is actually present in patient's oral cavity. So this gold standard method is like visual method, visual tactile method and radiographic methods. Now suppose patient visit your clinic for dental caries. If by using your gold standard method, patient is positive for dental caries, and then you apply your diagnostic test which you want to check. So according to this test, patient is also positive for dental caries. It means it is true positive. Now patient is not suffering from dental caries, but your test is saying yes, patient is suffering from dental caries. So it is false positive. Now patient is actually having caries, but your test is saying no, patient does not have caries. So it is your false negative. And patient does not have caries and your test is also saying no, patient is not having caries. So it is true negative. So what is primary goal of this effective diagnosis and treatment planning? It means why we are applying proper diagnostic methods to diagnose this dental caries and then treat this. To early detection of incipient caries lesions and caries activity process to prevent further tooth destructions. These individuals are identified according to their caries risk levels. Certain tests are undertaken which foretell the person's susceptibility or risk to caries. These are known as caries activity test. So with help of this caries activity test, we can understand the caries risk levels of an individual. Based on that, we can segregate the persons into high risk group and low risk group. This high group risk people have more chances of dental caries, and low risk have low chances of dental caries. And according to that, we can choose our proper treatment plan. Next is problems associated with diagnosis of caries. It means whenever we are diagnosing this dental caries, we have some problems related to that, like initial caries, proximal surface of enamel have caries, then secondary caries under the restoration, and root caries beneath the gingival margin. So these are some hidden areas which is not visible easily. For this hidden areas, we have various diagnostic aids with which we can effectively diagnose the disease process, severity and status. In this picture, we can see this is the initial caries. Differential diagnosis of this initial caries is hypocalcification or fluorosis. This is enamel proximal surface area caries, and here we have caries under restoration, and these are root caries under the gingival margin, or we can say beneath gingival margin. Now next is examination of teeth. So before starting examination of this teeth, we are following some preparatory steps. In this, we are following the teeth should be dry, clean and well illuminated. Other than this, we require some instruments like mouth mirror, periodontal probe and explorer, or we can use a scaling or cleaning to proper diagnose dental caries, because sometimes we are just misdiagnosed with dental plaque. Or we can also use floss to clean interproximal surface area and to find a smooth surface caries which is present in proximal side. And also we can use this cotton rolls in vestibule of mouth or beneath the tongue to maintain our area dry and clean. Next is aids. So clinical dentistry required an evaluation of the finest details of the teeth and restoration. Unaided vision may miss some of the details of the teeth, which requires magnification aids like magnification loupes. And to diagnose proximal surface caries or smooth surface caries, we have to use dental floss. If still it is not that much visible or we cannot find particular lesion, then we have to use temporary elective tooth separation. In magnification loupes, there are various types of magnification loupe like high resolution loupes, mini loupes and prismatic loupes. We can choose one among them and can be used clinically to assess or to examine the teeth visually. So for which usually the operators will select 2 to 4x magnification loupes. So these are major 3 aids that we use along with visual tactile method in order to diagnose caries. Now coming with visual methods, this is very popular method. Sensitivity is low but high specificity. It helps to detect us non-cavitation enamel lesions on smooth surfaces and also anterior proximal surface area, clinically detected cavities limited to enamel, dentin lesions with cavitation on smooth surfaces, secondary lesions with cavitation and active and inactive root lesions. The visual caries assessment can also be done by a system that is called as International Caries Detection and Assessment System, which means ICDAS. This ICDAS uses a two-stage process to record the status of the carious lesions. The first is a code for severity of the caries lesion and the second is for restorative status of the tooth. So this is your first code which we are using for checking of dental caries, and another one is second which is used for restoration. In first code we have 0 to 6 and in restoration we have 0 to 8 codes. So in this lecture we are seeing this caries process. It means first code. So starting with 0, it is sound tooth surface. It means no presence of any type of caries. Then we have code 1, which means first visual change in enamel. This is just a starting phase of enamel caries. Then 2 is for distinct visual changes in enamel. Then 3 is localized enamel breakdown due to caries with no visible dentin. So according to that we can say this 1 to 3 is for enamel caries. Then code 4 is for underlying dark shadow from dentin with or without enamel breakdown. Then 5 is for distinct cavity with visible dentin and 6 is extensive distinct cavity with visible dentin. So these are caries which reached to dentin. Now comes the most challenging part, that how you detect this white spot lesions. It means WSLS. So the clinical examination reveals localized intact hard white areas on the facial or lingual surface or on the cusp tips of the teeth. So these white spot lesions are hard to differentiate from hypocalcifications. In this, we are using the technique in which we are just weighting our tooth so that if this white spots will be disappears, then it is white spot lesions, or we can say smooth surface incipient caries. But if it is visible after a weighting of tooth, then it is a non-hereditary enamel hypocalcification. So in this image, this is for white spot lesion and this is your enamel hypocalcification. So as you can see, these are opaque white on dried teeth, and this is enamel hypocalcification. Again, chalky white appearance is seen. Now comes to our clinical tactile method. In this, apart from visual method, we are using instruments to diagnose this dental caries. So combination of light, mirror and gentle probing. As you can see in this image, light probing and mouth mirror. This is used in most epidemiological studies in US. So there are two different schools of thought. The American epidemiological study states that we can use explorer to assess the teeth, whereas the European epidemiological states that no, we should not use explorer as it can cause cavitation into oral cavity. So first let us see the criteria. It softened enamel catches explorer and resists its removal. Then these teeth are neither cleaned or dried. We are not using any scaling before assessing this teeth. We are just checking this as it is and we remove the debris with use of explorer. It takes about 3 minutes per subject, or we can say per tooth. It allows the explorer to penetrate proximal surfaces under moderate to firm probing pressure. So we should not apply too much pressure with an explorer. Studies have found that this would not increase the accuracy of caries detection. So we should be gentle enough while using the explorer. We should not apply too much pressure so that we actually tend to form the cavitation. If you see this picture, you will actually understand how much pressure we should apply with an explorer while assessing or diagnosing the dental caries. We should apply enough light pressure which is applied to blanch our finger nail. So when you apply an explorer onto your nail, the amount of pressure required to blanch your fingernail is sufficient to examine your teeth. You should not apply too much pressure on the tooth. So what are the role of this explorers? An explorer is useful in caries diagnosis as a tool to remove plaque and debris and check the surface characteristic of suspected carious lesions. There is no need to apply too much pressure on an explorer because studies have found that this does not increase the accuracy of caries detection, as we already learned this. Now next is, some are saying we should not use this kind of probe or we should not use this explorer. So actually what is recommended? So we have to recommend community periodontal index of treatment needs. It means CPITN probe which has 0.5 mm sphere at the tip. Next method is trans illumination. So we have to place the mirror or light source on the lingual aspect of teeth and directing the light through the teeth. Proximal surface caries is present, then this area will become dark area along the marginal ridge. So in this image we can see we are placing source of light here and we will find a dark areas over here. It means there is presence of interproximal caries. Moving to next, which is our radiographic methods. They have great value in detection of those carious lesions which are not readily determined by clinical examination, especially on the smooth surface caries on the proximal side. So this is image for IOPA, and in this we can see this caries almost reach to the pulp. As we already learned that these are the problematic areas or hidden areas, as we don't have direct visual access to the proximal surfaces. Such areas or subgingival areas or root caries can be detected by radiographic methods. Yes, they do have certain limitations because radiographs are two-dimensional image, not complete. They won't give a complete caries extension three-dimensionally, although intraoral radiographs are generally used radiographs to determine the caries extent occlusally from the enamel to dentin towards the pulp. They play a very important role in caries detection. So majorly intraoral radiographs are used for detection of occlusal caries. For the proximal caries, we are using bite-wing radiograph mostly. Commonly used radiographic technique includes bite-wing radiograph, periapical radiograph and panoramic radiograph. So starting with conventional bite-wing radiography, in this we can see maxillary teeth and mandibular teeth. This disclose sites inaccessible to other methods like visual method or visual tactile method. It records the coronal portion of both maxillary and mandibular teeth in one image. It detects interproximal caries and evaluates the height of alveolar bone. Now next is intraoral periapical radiograph. It helps to identify early lesions and localization and extent of lesion. We can monitor the progression of this lesion and to choose a proper treatment plan. So in this image you can see a proximal caries which already reached to the pulp. Now this is a line diagram showing a caries extent. So 0 means no visible radiolucency. It means there is no presence of proximal caries. 1 denotes radiolucency in the outer half, which is half of the enamel. So you can see in this line diagram, it is slight amount of enamel is affected. Code 2 denotes the radiolucency in the inner half, which is more than half of enamel up to enamel dentine border, or we can say DEJ, which is dentino-enamel junction. So you can see here half of the enamel is affected. Code 3 denotes radiolucency in the dentin. In this broken enamel dentin border but without obvious spread in the dentin. Reach to the dentin but is not spread in the dentin. Next is code 4, which is radiolucency with obvious spread in the outer half of the dentin, which is halfway through to the pulp. It already starting in dentin and some amount of dentin is affected. Then code 5 is for radiolucency with obvious spread in the inner half of the dentin. It means almost half of the dentin is affected from the enamel to dentin. Next is panoramic radiography. In this mostly we are using OPG. So this panoramic radiography is considered a supplement to rather than a substitute for intraoral periapical radiographic series. It is valuable when disabled patients are examined like OSMF patients. The only inherent drawback is lack of image details for diagnosis early carious lesions. Adjunct bite wing and selected periapical radiographs are required for that task. That's why we are not frequently using this OPG to just diagnose proximal caries or any type of caries because they have lack of details. So in this image we can see there is presence of proximal caries here, but we cannot actually see the extent of this caries in OPG. Now next is digital radiography, which is filmless radiography. RVG is an example of digital radiography, and nowadays we are using this RVGs only, but in colleges still we are using that intraoral periapical radiograph, which is IOPA. It is introduced in the mid-1980s by Francis Moyen. A digital image is an image formed and represented by a specially distinct set of discrete sensors and pixels. There are mainly two methods in digital radiography. One is direct digital imaging and another one is indirect digital imaging. Now, next is Caries detector dyes. After using all the methods, one method which we can use is Caries detector dyes. So there are various dyes have been used. For enamel caries, we are using calcine, Zyglozedel 22, Procyon and Brilliant Blue. For dental caries, we are using Fuchsin, Acid system and Methylene Blue. Procyon dyes produce irreversible staining, which would be clinically unacceptable. It reacts with N2 and OH- groups of enamel and act as fixative. So, we are using this dyes to diagnose a disease, or we can say caries. We are not promoting destruction of any tooth structure. So, this Procyon dyes is not acceptable. How we are using this dyes? So this is any brand advertisement. Brand name is exposed. We are not promoting any brand here. So here we have a lightly weight exposed applicator with either water or wet tooth. Then we are applying this wet exposed applicator to the prepared tooth, and then we are rinse and examine the area for any exposed that remains on the affected dentin. So whenever we are applying this dye to our tooth surface area, if after rinsing dye is still present over there, it means there is destruction of tooth. So according to that, we have to start our treatment. Now moving to next, this dyes neither stained bacteria nor delineate the bacterial front, but did stain collagen associated with less mineralized organic matrix. So this dyes is just staining the collagen which is associated with less mineralized organic matrix. So we can find, yes, this is the area where actually caries is present. The routine use of these dyes without an understanding of their distinct limitations will result in excessive removal of totally sound tooth structure and increased likelihood of mechanical pulp exposure. So we should use dye when we actually know what is the use and what is the limitation of this dye. So in this image we can't see any caries visually, but when we apply dye and there is some stains present after rinsing, so then we have to start our treatment according to that. Last part of this video is conclusion. So diagnosis of caries activity is more important than caries severity. Combination of more than one diagnostic tool is recommended for diagnostic purposes. Each diagnostic tool has some limitations at different level of severity. So that's all about today's video. Thank you so much for patience listening. If you have any doubt related to this, let me know in comment section. Thank you.